to the Global Child Dental Fund and the World Federation of Public Health Associations Oral Health Group. I'm Ram Bedi, a Professor Emeritus at King's College London and Chair of both the Global Child Dental Fund and the WFPHA Oral Health Group. Today's seminar is on COVID-19 and the role of silver diamine fluoride and urgent dental care. We have on the panel two experts, Dr. Ali Attieh, who is a well-known pediatric dentist and president and chairman of the NYCA Management Service Organization, which run a network of pediatric dental clinics in New York. And we have Professor Prateep Panatumvanit, who is chair of the National Oral Health Strategy Committee in Thailand and a former dean of the Faculty of Dentistry, Thammasat University. This seminar is not being sponsored by any organization or company, and no one on the speakers and myself are being paid or have any commercial arrangements with any company. Ali and Prateep, welcome to the panel discussion.
Thank you.
Hello, yeah.
Thank you. And
on March the 15th, the New York Times ran an article highlighting that dentists are one of the most likely workers to be exposed to the risk of COVID-19. They called for clear guidance for dentists into managing patients in this pandemic. Now, we're going to assume that we all accept the fact that all patients should be triaged. Advice, antibiotics, analgesics, the 3 A's should be the routine type of care and advice given to patients. But patients then who do have persistent problems and pain, particularly exposed dentin, will need face-to-face engagement with a dentist. So Ali, can you just share with us what's happening in New York and what type of approaches are your dentists in your network approaching?
So in New York, as you know, we are currently on lockdown and or shelter in place, and we have shut down all of our locations for routine care. And we are right now instituting a telehealth, what we call a telehealth, or you can call it a teledentistry mode of allowing patients who have emergencies to contact us, fill out an online form, upload their images of the areas that they're complaining about. Then that is being looked at by our doctors on call. We initially engage with them through text, followed by phone call, and then we make determination as to whether there is requirement for face-to-face contact, or is this something that, as you mentioned, can be taken care of by antibiotic or analgesics. And if it's face-to-face, we go in and we take care of them.
Okay. So Ali, just run through with me, because some of our viewers will not have come across silver diamine fluoride. So just run through silver diamine fluoride and how you actually use it in your patients, and then how do you use it in urgent dental care in this pandemic? So
we have been using silver diamine fluoride as a routine part of our dental treatment. Silver diamine fluoride is a caries arresting agent that has been very, very effective in arresting decay. And we basically, for any patient in a routine care that we cannot handle or we cannot treat based on the ideal treatment options of caries excavation and routine restoration, we're just going to apply that, which is right now a blue colored liquid, looks just like Bond, that we just paint onto the caries lesion. We're doing the same thing now in cases where we have to go in and take care of a child that actually is showing signs of papitis, where they're having a dental pain, and at this point we're not instituting any aerosol producing procedures such as using a handpiece we just go in and we look at the lesion. As long as the lesion does not look to be too close, which our standard is less than a millimeter to the pulp. As long as it's not less than a millimeter to the pulp based on radiographic examination or visual clinical examination, we go and apply that onto the tooth once we've dried the lesion. And then we cover it with fluoride varnish. And we find that this approach works very, very well in relieving the sensitivity and pain and temporizing the patient. We don't always cover it as a follow-up with glass ionomer, but sometimes we do that as well.
So it's simply by a solution put on a microbrush and you just paint it into the cavity or the exposed dentine.
Yes.
And that should be as simple as that. So it could be done in the clinic, it could be done in care homes, it could be done in lots of different situations, and no aerosol and no triple syringe is needed.
No aerosol, no triple syringes. Now, in the past, sometimes we have used the air water syringe to dry the area, but as of right now, we just use gauze or cotton rolls to just dry the area and make sure that the area is as dry as possible, and then we just apply the silver diamine, and it's quite effective.
So on two issues here is, one is, how long, in your experience, does that relieve the symptoms?
So this varies, of course. We are not exactly sure what all the different factors. One of the factors is, of course, the size of the lesion. The other one is how well you're able to dry the area. And lastly, how long were you able to apply the silver diamine fluoride onto the lesion. So considering all those variables, we find that if you've been able to manage those things and you're not dealing with a particularly hot tooth, you can see pretty immediate result in terms of patient not having the pain. But again, there's a great deal of variations in each of those areas that I discussed. So where we really see the effects is within a week. Within a week, we see, I would say, 80 to 90% of the patients that you've treated that, as far as pulpitis or pain goes, that has resolved.
Okay. So in urgent dental care, a patient would come, and in this pandemic scenario, there would be a tooth that is sensitive. But surely SDF could also then be used for other cavities in the mouth to prevent the patient coming back again a week or so later with another problem. So a degree of prevention is also there available. Is that a strategy that you approach?
Most certainly. That is most certainly the strategy that we are not only engaging in now, but that we've been engaged in all throughout our practice ever since introduction of silver diamine fluoride. So even before this pandemic, even before all these limitations, you would typically have a child that would come in, you do one lesion that is the area of complaint, but you still look around the mouth and see what other lesions are there that the child may not be complaining about, and you still apply it onto all of those lesions to buy yourself time until the child can come back and you can make an appointment and address those. So this is something that we've been doing all along, and most certainly are doing it now as well.
Good. Ali, thank you very much. Prateep, can I just bring you into this discussion now? Is that the approach you're taking in Thailand and in other Asian countries, which I know you're involved with?
Yes, actually, we are using a bit more on ART or silver ART in our regions in the normal situation. But I think when we are talking about in this COVID situation, when we are talking about the urgent care, I think the SDF have a big role to deal in the caries. Even in the deprived, unless it's not exposed, you can use the SDF, But if there's a cavity, you can use SDF and plus with the high strength glass ionomer on top of the glass on top of the SDF. That can be done also, and so that can be a good healing for the long term. Because we know that we will stay with the COVID for a few months, or I don't know how long we will stay. If we are doing nothing, it's not good. Only it's stopping the progression of caries is good enough. As Ali mentioned, it stop the pain is good enough. But we still would like to let them be able to function. The teeth can be used. So I think if we can add a little bit on the gas ionomer and the high strength gas ionomer on top of this SDF, it should be very useful together, I think.
Okay. Well, I think that's useful in urgent dental care because we don't know how long we're going to have limitations in providing routine dental care. It could be months, it could be weeks, we don't know. So your advice is that where possible, you can put the SDF, silver diamine fluoride, in a microbrush, in the cavity or on some exposed dentine, and that will desensitize and arrest the decay, stop reinfection. And then your advice is to put a glass ionomer, if possible, just placement of a simple glass ionomer as a temporary restoration.
Right. I think this. I think I understand that in US they call it an interim restoration or something like that. But in the European country or in our region, we call it's almost similar to the restoration. If it's still there, it can be. It lasts a few years. From our experience in this region, it can last a few years. Definitely, especially it depends on the cavity. If it is class 1, it's definitely no problem. But class 2 may be a bit shorter, but it can use as a restoration as well.
Could I just ask both Ali and Prateep, in low-income countries, there's going to be much more risk because they will probably not have personal protection equipment, the PPE, and also they'll be limited in costs and resources. So Prateep, in your experience, because I know you go to Laos and you go to Myanmar, what would you advise dentists there as urgent dental treatment in this pandemic?
Yes, thank you. I think in this region, as you said, maybe even the dentists, they don't have the equipment. I mean, talking about the public health dentists with the government mainly, because in this region, the dentists only maybe less than 50% is working as a private one, but another 50% working with the government mainly. This government, they cannot supply all the equipment that the dental unit, dental share or something like that. So something like this, SDF and silver ART or smart or something like that, it will be useful because it can be done in any situation. We don't need the dental unit, something like that. We can use only the spoon excavator. I don't know, Ali, we are using the same. I think we are using the same, that we use only the cotton. We don't even using the three-way siling because no need to use it. And especially in this situation of the COVID, that the ADA said that you are not using the aerosol producing anything. Even the three-way siling, they say that you should not use it. So in this situation, we don't need it at all. We just use a cotton, we saw cotton pellet and using here and there. It's very simple and it's cheap also because you don't have to buy the equipment and something like that. In terms of the cost of the material, a little bit more expensive than amalgam or composite. But I think when you're thinking of overall of the equipment, I think this technique might be practical in the European country as well. I think.
It is. No, I think you're right, is that we should avoid any splatter. So that means no triple syringe, no creation of droplets, aerosol, high speed, scalers, airflow, all those should be not used, and that prevents airborne. So you're absolutely, I think I agree with you. Cotton will roll for some degree of isolation and saliva control, and just with a microbrush, place into the cavity. Ali, can I come back to you and just talk about the situations I think in the new world we're going to find ourselves? There's going to be areas like care homes, there's going to be confined areas like prisons. Where do you think SDF will play in urgent dental care there?
Oh, I think SDF is going to serve an invaluable role in those areas as well. We've already known, unfortunately, Richard was not able to join us today, but we already know that there are places where that's already been used, both in care homes and in the prison system. And we have one of our dental clinics is an adolescent dental clinic that's actually within a juvenile detention center, which again, in which we do use this as we do in all of our other clinics. And as was mentioned, the key is arresting the decay, getting rid of the pain, which is very, very easy and now can be done with no creation of aerosol, because as I mentioned and was mentioned previously, we can just use cotton roll and cotton roll isolation for, and then additionally, just putting glass ionomer or glass ionomer restoration wherever there's cavitation, wherever you feel that that can hold. And in the class 5 lesions that you see often in the geriatric situations where you can need it, or in the prisms, it's certainly something that can be done. And depending on what kind of glass ionomer you're using, if you just use the old school powder and liquid, it doesn't even necessarily have to be as expensive. And, of course, the superior products are the capsules that are a little bit more expensive than amalgam. But still, as long as you get some glass ionomer into those cavities, even in those situations, it can go a very long way in both arresting the decay and buying quite a bit of time before that patient needs restorative or in any sort of invasive dental care at that point.
Sure. Okay, to summarize, and thank you both very much. To summarize, it seems to me that there is a universal acceptance that all dental care in the pandemic should be non-aerosol related. Avoiding of splatter, avoiding of any type of airborne and aerosol activity. We all agree that all patients should be triaged. There should be advice given, there should be analgesics or antibiotics, but there will be people who will need to be seen by the dental team on a face-to-face basis. For those individuals, it's universally accepted that personal protection equipment is needed, that no member of the dental team should actually engage with these patients, possibly infected or actually infected, without personal protection. But I think we've highlighted, and thank you both for highlighting, that a part of the equipment that the dentist should have is silver diamine fluoride. It arrests the decay, stops reinfection, can be done simply and easily, but more importantly, it stops other cavities becoming problematic and the patient having to revisit. So you have the chance to arrest the other cavities. And I think that's one of the great advantages of SDF. Otherwise, the treatment is suspect, and it's because it's going to be so difficult to get patients to have face-to-face engagements. We want to take advantage the best we can. So thank you both very much. It's very illuminating, and I think the experience from Asia and from North America has been really interesting, and it's showing us that there is going to be a new world in dentistry, new approach to care, and this pandemic will begin to change, I think, our approach to provision of dental care for people. So thank you both very much.
Thank you.
Okay.
Thank you.
Thank you.